All right, good morning. Welcome to In the Trenches with DAC. The topic requested of me today was hypothyroidism. I'm not enthralled about this because I don't know how much there is to say, but I'm going to attempt to speak 10 minutes on this. So hypothyroidism is not an uncommon problem at all. And normally it is due to Hashimoto's thyroiditis. More common in women, but you can see it in men. When do you suspect it? I mean, most of these cases are not, obvious. If somebody's gained weight, if they're more lethargic, constipated, cold intolerance, they're losing hair, they're thinning of the eyebrows, yeah, you think about it. You're examining someone and you suspect hypothyroidism, and you check reflexes on them and they're hung up and they contract but they don't relax. Yes, you suspect that, or if they have a big tongue. But normally, these are patients who are at the severe end of it. It could be very subtle. The test that rises is the TSH, okay? And if this is elevated and the T4 is low, or the T4 is even normal, if it's normal, it's called subclinical hypothyroidism, then the patient's hypothyroid. And you're gonna get thyroid peroxidase antibodies. You're going to get an antithyroglobulin antibodies. These are the immune markers. Sometimes it's a debate when you're going to treat somebody if the TSH is borderline, and the presence of antibodies could predict which patients will become more symptomatically hypothyroid. Another thing you need to worry about hypothyroidism, this causes hyperlipidemia, and if you have this for a long period of time and this is not treated, you could wind up developing atherosclerosis or premature atherosclerosis because you have decreased LDL receptors. And frankly, any patient who's hyperlipidemic, okay, you should really check thyroid function. Somebody who has had hair loss, you should check thyroid function. They're all degrees of hypothyroidism, and sometimes in the elderly it could be tricky to pick up. Now, what else could cause hypothyroidism? If somebody has had surgery and had their thyroid removed for cancer or Graves' disease, or if they had radioactive iodine treatment for Graves' disease, they can become hypothyroid. That's not autoimmune. Certain inflammatory conditions of the thyroid, such as subacute hyperthyroidism, de Quervain's, or any type of thyroiditis, initially they could become hyperthyroid, and then they could become hypothyroid, and some of them remain hypothyroid. An interesting fact, the DRESS syndrome, drug rash with eosinophilic and systemic symptoms, these patients, when they recover from this, a certain percentage of these people become hypothyroid on an immune basis. And hypothyroidism can be seen with other autoimmune processes. They're the polyendocrine deficiency syndromes. So type 1 polyendocrine deficiency syndrome, you see it's adrenal insufficiency and hypoparathyroidism and candidiasis. But type 2, okay, is adrenal insufficiency, diabetes, and hypothyroidism. So you can see with adrenal insufficiency and other autoimmune conditions, once again, this is autoimmune. So, sometimes it's easy to detect, and sometimes it isn't. I remember during the training, there was this one man who was admitted, who was severely constipated for years, and back in the 80s, there was a much lower threshold to admit, and his TSH was very, very elevated. In my practice, I took care of somebody, and this man couldn't move. He was myxedemosis all over. His tongue was huge, and his TSH was over 1,000. And I slowly corrected him, and I actually had to make house calls because he couldn't get to my office. And after over a year, I got him euthyroid. He started developing angina, and he wound up getting emergency coronary bypass syndrome. And of note, eons ago, when they had no meds for angina, often they would remove the thyroid to decrease the body's metabolism and decrease the myocardial O2 requirement. Obviously, that was a very, very long time ago. So if you have somebody who's hypothyroid, you have to give them back what they're not making, and it's usually not that complicated. And if it's a young person, you're going to start with either, usually it's 1.6 mics per kilogram, that's normally what you start out with. If it's an older person and you're correcting this, you have to be more cautious. And there's the old adage with that: start low and go slow. So you might start with 25 or 50 mics, and then up the dose gradually over a period of time, is not to make them instantly euthyroid. What about myxedema coma? This is a clinical diagnosis. The patient's obtunded. They're usually bradycardic. They could be hypoventilating. And with something like this, these people are peripherally clamped down. Okay, so they have increased alpha tone, decreased beta tone, and you can't really give them oral Synthroid. They won't absorb it. So you have to give it IV. The IV dose is more potent than the oral dose. So you kind of figure out the oral dose, and to correct it, it would be about 75% of the oral dose you give IV. But if somebody's very hypothyroid, you might have to give them a little more. And oftentimes, these people are severely constipated, their bowels don't work. What is very important, that if somebody comes in myxedema coma, unless you can prove otherwise, you have to assume they also have adrenal insufficiency. And before you give thyroid hormone replacement, you need to give stress dose hydrocortisone, 100 milligrams IV Q8 hours. You could taper it rapidly, but from the get-go, you need to do that. That's basically what I have to say about hypothyroidism. This is a common outpatient problem. You correct it over a period of time. It's usually easy to correct. You're going to give a person what they're not making. It's more common in women than men, but you can see it in men. And there's usually not an extensive workup involved. You need to make sure they're not on a medicine that could cause it. Now, amiodarone has iodine in it, and sometimes iodine could cause hypothyroidism. That's what's known as the Wolff-Chaikoff effect. So you need to be aware of that. And if somebody's getting amiodarone, you need to follow thyroid function. They could also get hyperthyroid, but they could get hypothyroid. Sometimes this is an easy diagnosis to make. Sometimes it's very subtle because these patients aren't very symptomatic. And sometimes, when you have these TSHs that are borderline, an ideal TSH would probably be about 1.5. These TSHs that are borderline becomes a debate who you're going to treat and who you're not going to treat. And you need to follow it. But the patients who have positive antibodies, people who have positive antibodies are the people who are more likely to progress, and you may have a lower threshold for treating these people. That's all I'm going to say right now. In the trenches with DAC. See you next week. All right.